Hello, I hope all is well. Today I'm going to provide a case presentation and how to manage a case with medical management. This case is pretty close to me. It reminds me I had the same diagnosis of this patient, and some of his delusions remind me of some of the delusions I had when I was psychotic. So we can look through this case and I may provide you with some anecdotal experience from my history with bipolar I with psychotic features and what I went through. So let's look at this patient. EF is a 22-year-old male. He has been admitted to the hospital following an arrest. The patient was walking down the highway and throwing traffic cones at cars and at police, saying he was trying to evade police. His chief complaint is EF is worried about side effects of his current medication regimen. Specifically, he does not want to develop pseudo-Parkinsonism symptoms and other extrapyramidal symptoms. So let's look at his medication list. Most of his medication list is unremarkable. A lot of our patients are prescribed this bundle package of as needed medications in case they ever needed to use them. But his psych meds are Seroquel 300 milligrams BID, Vistaril 50 milligrams BID, and cogent is not really a psych med. It's used to prevent extrapyramidal symptoms. So let's look at his psych history. He has bipolar affective disorder with psychotic features complicated by alcohol, marijuana, and cocaine abuse with symptoms of depressed mood and past. And this is sort of what happened to me. I started off with depressed symptoms and I went to see a psychologist and a psychiatrist and they put me on antidepressant, and that's what triggered my first manic episode. So when bipolar I presents itself, it's often the depressed symptoms, and we have to differentiate between major depressive disorder and bipolar depression. So my first psychotic episode, I have delusions that are common with manic episodes. I thought I made like $100 million. I thought I could quit school. I was acting very strange to all my teachers and professors, being argumentative. So eventually I was taken to the hospital. So his psychotic delusions, he believed the devil and gargoyles were after him. I had a similar delusion my first and second psychotic episode. I believed that actually businessmen were stalking me and people dressed up as businessmen were stalking me. And I had crazy delusions like the internet. People were hacking my computer and manipulating me through my computer and speaking to me. And he also had auditory and visual hallucinations. I didn't have auditory hallucinations, but I had a delusion that the dead were talking to me through my thoughts. Like I thought Salvador Dali was saying hi to me, and I'm doing good. Patient was hearing voices and seeing gargoyles. I do not believe I was seeing anything. I just had wild delusions, like the world was ending and it was restarting. I was eating plants because I thought everything was turning into edible. I was eating poisonous plants that made me vomit. And he had thought broadcasting. Patient believed radio was talking to him, stating, "We are going to get you," and assaultive behavior. Patient was throwing items at others. He has not been on psychiatric medications prior to his most recent incident. Since starting Seroquel, EF no longer hears voices or believes people or things like gargoyles are after him. Alright, so let's look at his objective signs. His complete blood count is normal. He's Hep C negative. His thyroid labs are normal, including his TSH, T4. His parathyroid hormone level is normal. His comprehensive metabolic panel is normal. He's HIV negative. His liver function tests are normal. His A1C is normal, so he's non-diabetic. His lipid panel is near optimal. His B12 and folate is normal. And vitamin D, he has deficient levels of vitamin D. I think the level was 16. And then he's PPD negative, meaning he doesn't have tuberculosis. So his most recent vital signs, his blood pressure is 132 over 73. His heart rate is 89. His respiratory rate is 18. His temperature is 98. His O2 sat is 95%. His height is 5'10". His weight is 255 pounds, which means his BMI is 36.6, which is obese. So for his mental status, EF appears to be stable with current psychiatric therapy. At the hospital, he is working out constantly and has lost 30 pounds in 3 months. He is pleasant, cooperative, and socializing with peers and staff. His thoughts are goal-directed, and he denies hallucinations and delusions at this time. His goal is to get out of the hospital. So, since he's working out constantly, I thought that this may be residual mania, because when I had manic episodes or was hypomanic, I would also work out constantly, and I was constantly going to the gym or running. I just had all this excess of energy. But this is something he said he's done before, and it doesn't look like he has any other indications of being manic. So I may just applied my history to this case, which is not good because every case is unique and everybody's psychiatric history is unique. Okay, well, let's look at his assessment and plan and what we could possibly do to his medication management. His first concern was polypharmacy, and he's on 3 drugs that are related to his psychiatric condition. He's on benztropine or cogent. The patient is not currently exhibiting any extrapyramidal symptoms, so benztropine would be an unneeded treatment. Benztropine can cause anticholinergic side effects such as tachycardia, constipation, dry mouth, memory impairment, blurred vision, and urinary retention. There's a helpful mnemonic that helps us remember anticholinergic side effects. It's hot as a hare, red as a beet, blind as a bat, dry as a bone, mad as a hatter, and full as a flask, which means urinary retention. Quetiapine is the only potential agent on the patient's medication profile that could cause EPS symptoms, but it is the weakest binding antipsychotic to dopamine 2 receptors, making it theoretically the least likely antipsychotic to cause extrapyramidal symptoms. However, this can be debatable because Seroquel requires higher doses to get that antipsychotic activity. Patient is also on hydroxyzine. The patient does not currently complain of anxiety. Anxiolytic effects or anti-anxiety effects occur quickly with hydroxyzine, like benzodiazepines, but is non-habit forming and does not cause tolerance, withdrawal, or memory impairment. Hydroxyzine's anxiolytic effects are due to modest serotonin receptor antagonism in addition to histamine 1 blocking effects. It is also believed that hydroxyzine is a H1 receptor blocker. Well, it is, but it's believed this in turn raises GABA in the brain, and this increase in GABA helps decrease intracellular serotonin levels. This means that there's more serotonin levels in the synaptic cleft, which means it could potentially act as a weak serotonin reuptake inhibitor, causing anti-anxiety effects. The sedative properties of hydroxyzine can cause unwanted drowsiness, but could possibly only be transitory. Seroquel is currently the backbone of the patient's medication regimen for maintenance treatment of bipolar affective disorder with psychotic symptoms. In comparison to other antipsychotics, Seroquel has a favorable side effect profile. It has very low muscarinic or anticholinergic receptor activity. It does have cardiometabolic side effects, including weight gain, hyperglycemia, and dyslipidemia, so it's important to monitor that occasionally. Seroquel has a short half-life, so it requires twice-a-day dosing, and it could cause discontinuation syndrome if stopped abruptly, but usually resolves in 1 week. Discontinuation syndrome is a syndrome if somebody's stopping psychotropic medication with a short half-life. It also occurs with duloxetine. It can cause gastrointestinal symptoms. It can cause cognitive symptoms. It can cause all sorts of things. So it's important, if we're going to taper somebody off Seroquel, we do it slowly. The most reported and concerning side effect is drowsiness for Seroquel. Seroquel is also unique because it can be used for insomnia. It also has antidepressant and anxiolytic and antipsychotic effects. So the plan is, due to the patient not exhibiting any extrapyramidal symptoms and desire to be on less medication, we can make benztropine a PRN or discontinue. Likewise, the patient states that he does not feel any anxiety, so we can keep the hydroxyzine on the patient's profile as a PRN, especially since it works right away, and if he needs it, he could take it. Okay, now let's look at his bipolar affective disorder with psychotic features. Patient had very severe psychotic symptoms that put him as in danger to himself and others. Patient was wondering if he needs to really continue the Seroquel. Patient will have to decide if it is worth taking an antipsychotic to help prevent another severe psychotic episode. After my first episode, I was on an antipsychotic for a year with no trouble. And my psychiatrist, he felt that a year was all I needed to be on antipsychotic. But as soon as things got stressful again in school, I was missing sleep or losing sleep, not getting much sleep. I had high stress levels. I got a second manic episode. So we need, if somebody has bipolar affective disorder, all of us need to decide if taking an antipsychotic to prevent another manic episode is worth taking the drug and possibly tolerating the side effects or potential long-term side effects. Seroquel is the backbone of patients' medication management, is well established in the treatment of schizophrenia and manic episodes. Seroquel is kind of neat because it has an active metabolite called quetiapine, which selectively inhibits noradrenaline reuptake, is a partial serotonin 1A receptor agonist, which is similar like buspirone is a 5-HT1 receptor agonist. Actually, most atypical antipsychotics are 5-HT1A receptor agonists, except for risperidone and olanzapine. Seroquel also acts as an antagonist at presynaptic alpha-2 adrenoceptors. This shares a mechanism of action of mirtazapine, which is an antidepressant, and then it acts on the 5-HT serotonin 2C receptor, which can help with anxiety and depressive symptoms as well as affective symptoms, and also on the serotonin 7 receptors, which is procognitive. In this receptor profile, it could result in negative and cognitive symptom improvement as well as have anxiolytic or antidepressant effects. So what's the plan? Currently, the patient is tolerating Seroquel well and does not need a dose adjustment. I recommend to continue current medication regimen and provide peer support opportunities. Discussing with peers could be beneficial because they can reinforce the importance of taking antipsychotics and can tell stories about what happens when we go off antipsychotics and if it's really worth the risk. Having a manic episode can be life-ruining. The patient has several risk factors for treatment non-adherence, including male gender, younger age, and low socioeconomic background. It is important to build a strong rapport with healthcare providers to help patient gain insight into his illness. We can revisit in the future to decide if the patient can be stable on a lower dose of Seroquel. This is the patient's first manic episode, and it could have been triggered by drug abuse, so there's somewhat debate if he really needs to continue on Seroquel as long as he doesn't do drugs, and if we can trial him going off Seroquel. But a lot of providers believe that once somebody has a manic episode, they should be on medication, a mood stabilizer, or an antipsychotic for life, just because manic episodes can be so severe and so life-ruining. Alright, and the patient is vitamin D deficient, and the reason I'm bringing this up is because there's research going on that vitamin D may be beneficial in those with schizophrenia, bipolar, or depression, and we'll talk about that a little bit and why this patient is on 5,000 milligrams of vitamin D 2 times a day. Individuals with psychotic disorders are more likely to have vitamin D deficiency, and vitamin D could have potential beneficial effects on brain biology, including neuroprotective effects. Studies measuring the benefit of vitamin D supplementation are heterogenic, and this could possibly be due to the studies not using a high enough dosage of vitamin D. This is an example right here of a study that showed a higher dose of vitamin D has beneficial effects on the Beck Depression Inventory Scale in patients with major depressive disorder. The research is still ongoing, but the plan is to continue 5,000 units of vitamin D twice a day to restore vitamin D levels pretty rapidly, and also to keep the patient on it for its potential benefit and its low risk of adverse drug reactions. There is some concern that can cause too high calcium levels, which can result in cardiac effects, or it can have other cardiac effects, such as calcification of the soft tissue and arteries. So there are risks, but they are minimal and rare. The patient also had cardiometabolic issues. He was obese. He's currently exercising frequently and he's losing weight rapidly, has lost over 30 pounds. And there's no medication management needed at this time. And then the patient also has heartburn or gastroesophageal reflux disease, and we're just going to continue current therapy. That's working for the patient, and there's no need for changes at this time. And that is it for this patient EF. I saw a lot of similarities between this patient and myself. My first manic episode was when I was 21. My second was when I was 26. So that about wraps it up. Here is the list of resources in case you're interested in exploring a little bit more or reading a little bit more about some of the information presented in this patient case. And I hope you have a nice day. I look forward to seeing you in the future. I'll scroll through this one more time slowly. All right. Have a good one.